Today we are talking about ketamine.
Okay, we're talking. Well, so I expanded it out to ketamine, psychedelic, or like psilocybin
Mm-hmm.
and MDMA because I thought they all like kind of were in the same category
Mm-hmm.
because they were psychedelics that were starting to be used for therapeutic purposes and
Mm-hmm. Mm-hmm.
assistance in like the therapeutic nature.
Mm-hmm.
And so those three for me kind of fit into like the same gambit. I don't think I did LSD in this one. I don't think we're going to be talking about LSD, but
Yeah,
I think it's just those three.
it's LSD has a funny history with recovery, actually, though.
Oh yeah, because what's his name used to do it?
Well, Bill and Bob,
Bill and
yeah,
Bob were like,
yeah. Dr. Kevin Winslow or something oversaw them clinically.
okay,
Yeah.
while they were doing LSD.
Mm-hmm.
Interesting.
Mm-hmm. And it wasn't just them. It was early, early 12-step history, and you look at like the efficacy and the outcomes and all that stuff. It's like they were extremely effective. Um, and when I found out about their experimentation with this stuff, I was like, I wonder if that contributed to it at all. And I found out about this in 2012. And then fast forward, like a decade later, and it's like all of the resurgence starts with specifically psilocybin and MDMA. And it is for different reasons
Hmm.
than what they were using it for, but it's still like there is still evidence that this stuff is effective.
Yeah, and I think what's so it's interesting because I did my master's degree in alternative medicine,
Mm-hmm.
and the whole idea around alternative medicine and the complementary alternative medicine program was how do you apply rigorous scientific principles to things that maybe not produced by the drug companies. And so, how do you take something that is in, common space right now, right? Ketamine, like you can't really like MDMA, like who's gonna really profit from that? Like, there's no patent for that. There's
Mm-hmm.
no drug patent for that. So it's how do I apply the rigorous standards of the scientific method in a double-blind placebo study to particular modalities that may not have the money that you would normally see in other drug trials.
You're talking about behind the actual studies and the proving.
Yeah, the proving that it works.
So it's funny because the military, they're the ones that are really pushing this stuff,
Hmm.
and so they have the money.
To go and say, okay, like because it's so effective and so useful, especially for the veterans that are like
Yeah.
within PTSD and stuff like that. I could
Mm-hmm.
definitely see that.
Yeah. So Colorado. Do you talk about this later in it?
No.
Colorado recently in 2022, um, they passed a bunch of series of laws around legalizing and creating pathways for clinics and different settings to use MDMA and psilocybin.
Hmm.
So it's legal there right now.
In Colorado.
Yeah.
I think it's legal in a couple states right now.
The
It's just not. It has to be in a very controlled setting,
Right. And it's
uh,
also not FDA approved, so they
right? So
they
it's
can't.
only for research purposes.
Right. And so what they're doing, they're trying to get it FDA approved. The last denial. So this was interesting to me. The last denial that they got in Colorado, it wasn't around the efficacy. It wasn't around the outcomes. It wasn't around whether or not these chemicals worked. It was around the way that it was administered. And so there were issues and there weren't safeguards in place.
Yeah, I get into that.
Oh, okay,
Yeah,
okay,
definitely. So we can talk about that as we go along.
okay, for sure.
Okay.
Okay, so what defines psychedelic assisted therapy?
Okay, so the classic definition, right, is anything that's mind expanding medicine for the healing of trauma. And it basically anything that creates an altered consciousness for emotional insight. And it's the idea that we're merging the neurobiology with spirituality and meaning. And the reason why some of these things have been worked on is because they found that it promotes surrender, empathy, and connectedness. And so it's being seen as a positive, but there's a lot of critics out there in terms of like what's going on. Like, are they just getting high? Are they like, is it really like therapeutic? Is there any way to prove this? Is it real transformation, or are they just escaping their reality and it's just one other drug that we're using to do that?
Yeah. Have you heard this stuff about saffron?
Yeah, you told me about that. I did read that study.
Yeah, that's a super interesting thing to like when you look at the efficacy and the outcomes and how similar what it actually does to the brain is,
Mm.
and then it's like, yeah, but it grows in your garden, so nobody's gonna profit
Well,
from it.
but saffron's also the most expensive
Oh yeah,
herb on the or spice on the planet,
yeah, yeah,
right? In
yeah, yeah.
terms of like weight.
Mm-hmm.
Um, somebody's making money off of that.
Oh yeah. Well, so their saffron comes from India.
I think so, yeah.
Yeah.
Or India or like the Middle East.
Okay, so but there is like a gold standard around saffron, and you'll see it. Who told me this? Was this you?
Now we were listening to that podcast.
Okay.
Um, the you told like when we were
Oh,
going
the
down
Diary of a
to
CEO.
yeah when we were going down to tap, you told me to listen to that, and what I came up with after I listened to that was that okay, like that's amazing. I'm sure it works, but it's comparing one thing that like might work to something that
For sure works.
for but no because it's you're comparing it to a an SSRI.
Yeah.
And what we've talked about SSRIs, right? There
Mm-hmm.
isn't like from the research that a lot of people have done, right? There have been no double-blinded studies on any of the medications they put out today, right? They're always randomized control. They're not randomized controlled trial. They are comparison studies.
Right.
So this drug compared to this drug, right, works a little bit better. So we're gonna give you a new patent around it, right? And so it's well, saffron works just as good as this one does, right? But the real question is, how well does this one actually work, right? And my proposal to you is that based upon the work that we're doing, none of them work really very well on any of that stuff,
Yeah.
and that the better way and the better mechanism to do it is not to look at it from a neurotransmitter perspective in the whole brain, is to look at what's actually dysfunctional.
Yeah. So it's a centralized issue, and treat the affected area
Right.
versus like try to globally fix something.
Right. And so the question is, why? Where did they come up with that theory? How did they come up with a theory that, like, hey, you're probably deficient in these neurotransmitters, and so we need to go ahead and give you a whole bunch of them?
Mm-hmm. So talk. So when you tell me about like, okay, these things were developed after the depression, and like when, like
Yeah.
all this stuff, it makes so much sense to me.
And when they were testing it, and when they were like, it's just the population has changed,
Mm-hmm.
right? The population that they were originally testing these drugs on was a population that came through World War II and the Great Depression.
Mm-hmm.
Like in my mind, their amygdalas were completely blown out.
Mm-hmm.
But what we're seeing today is poly-traumatized people where they have like little scarrings in their amygdala throughout, right? And so it's not an entirely demolished um, amygdala.
Mm-hmm.
And so SSRIs are amazing for regrowing amygdala cells. And so if you have a completely blown out amygdala and it's like the size of like,
A P.
a pea, and you start to regrow it, like of course you're going to start to get feelings back.
Yeah.
Right? And I think that that's for me the idea that it works, it takes a month for it to be effective, right? Like what's the mechanism for that? Why is that? And they can't really tell you why.
Really.
There's no like, oh, okay, here's it takes this long to do this, right?
I know what they tell like what I've been told, that
Okay.
it takes that long because there is like it has to build in your system. That's what I've always heard.
What has to build in your system?
I don't know. I don't even know what to ask at. Like it's like in my head it's like, okay, like it makes sense that if I'm deficient and this is like a slow acting drug or something. They're not explaining this either. I'm just like justifying what they're telling me.
Right.
It's like, okay, if it's a slow acting drug that like
The
has a really long half-life.
the example that really got to me was when if someone comes in bipolar in a manic episode, the very first thing that you do is you stop the SSRI,
Oh yeah.
right? And
Totally
so
makes sense.
if you stop the SSRI and you get that fast of a result from stopping it, why does it take a month for it to become effective?
So another thing about us, well, I don't know if we want to get into this, but
But
the
but this kind of goes into the point of the ketamine
mhm,
and what it's working on and what it's functioning off of, because the ketamine, and we'll get into it, right, has a really quick efficacy right off the bat,
okay,
right? And
yeah,
so one of the things that it does is that it blocks the NMDA receptor, Well, there are anti-seizure medications that do that too.
Really?
So if we've got a theory, right, that there's a hyperactivity in a very particular portion of the brain,
Mm-hmm.
um, what if that's what was being treated with the ketamine in that first episode?
Okay.
And the reason that it was effective for, the 1 week, the 2 week, the 3 weeks out was because you kept quieting down the amygdala
Yeah.
at that point. And then you were getting benefit because you were building new prefrontal pathways in a quieted amygdala
Mm-hmm.
while you were super neuroplastic. And then when it didn't work, 3 months later is because the amygdala was hyperactive again.
Yeah.
And then you have to do another cycle.
Yeah.
Right. And like that all fit for me, and that sort of made sense. Like I'm all for the idea of using a drug to quiet down the fight or flight response to get you into a state where you're hyperplastic. Like that. I mean, that's what we're saying,
Yeah.
right? We're saying the exact same thing, except for we're doing it with medications that aren't no, they're psychoactive, that aren't
Euphoria
euphoria
producing.
producing, and they're not that don't have a high they don't have an abuse potential.
There's no affinity for abuse.
Yeah, like no one's going out there being like, hey, like I'm gonna take more of my Depakote,
You
right?
know what's
Or like,
funny though? In prison, people overdose on Dilantin.
okay,
I mean,
interesting.
it's interesting because it is definitely at all. I've done it.
You've done a whole
Yeah.
bunch of Dilantin.
Mm-hmm.
Yeah, and I think so. One of the things about the medications that we're using is that I'm not using it to get a dopamine response from it.
Yeah.
I'm not using it to get you high. I'm using it to stabilize the membrane.
Okay, so why the resurgence in clinical use?
I think that they're like probably in the last like probably 10 years or so, they're seeing that traditional psychiatry medications were really failing people that had trauma based disorders. Veterans with PTSD, studies that were having patients be on ketamine revived kind of the legitimacy around all of this. And then the media created a public demand and the hype, right? And then also COVID drove a lot of this too because there was a lot of interest in, oh, like we're at home alone by ourselves.
Mm-hmm.
Everyone was having mental health disorders or issues, and they were like, what can we do to treat these people? I thought a lot of that was because of the isolation and a lot of the you weren't in your collective like safe environments and your spaces or your positive protective factors. But what's happening, right, is that the critics right now are seeing that there is a surge in enthusiasm, right? But there isn't anything that's actually validated. Like how much of this information that's out there is, driven by the data, or how much is it if it's driven by like, oh, anecdotally this works, or we've seen this work.
Okay, so anecdotally though,
Mm-hmm.
right? There's many things that can point to like this is really effective.
Yeah,
How many stories have you heard about vets who have done a single treatment, specifically of MDMA, but one single treatment of the medication, a long series of
yeah,
clinical stuff, right? But like one actual medically overseen treatment of the MDMA, and it reverses all kinds of things for them.
yeah. And it's phenomenal, right?
Mm-hmm.
And it has a lot of promise for the things that have been refractory to care before,
Mm-hmm.
right? But there's always, for me, there's always, it goes back to the question of like, why is this working?
Mm-hmm.
Why is it so effective? And we'll get into some of that stuff
Okay.
later on, right? But this stuff was interesting for me because especially if we start applying the model that we're proposing to this, it makes so much more sense as to why this is so effective, especially around MDMA and the release of serotonin and the release of oxytocin, right? During those particular states, especially if you're getting a huge dump of it, a huge flood of it, all of a sudden your amygdala is completely quieted down. And whatever you're doing during those times and the suggestions and the therapeutic value that you have during those times, maybe you're hyper building prefrontal pathways, right? And so that one instance gives you a complete frame shift around everything. But that's what some of the other drugs do, right? Like the ayahuasca.
Mm-hmm.
People go out there and they're like, I had this ayahuasca experience where I was a complete shift in my ego and the person that I was, and things that I've been holding on to forever, I was all of a sudden able to let go of.
Yeah.
Well, that for me is that's just building a new prefrontal pathway, right? And
Oh,
then
yeah.
reinforcing it really quick. Like we've talked about this. A new idea is a new prefrontal pathway, a
Yeah.
new idea that you hadn't thought about before, or a shift in your perspective that you adopt as your identity. And if these particular drugs create a state where you can have those huge frame shifts, then all the better. I'm all for that.
So, is there actual physiological mapping onto this theory where we talk about a new thought creates a new pathway? Does that map physically?
I mean, you wouldn't be able to do that because that's just one thread.
Okay.
That's like one neural pathway, right? So like you're asking me to map out, one neuron firing with another neuron firing with another neuron. That's one pathway. How are you ever going to
Okay.
see that inside of your brain,
Okay.
right?
Okay.
But I mean, theoretically, right? That's a new pathway. Every new thought has to be originated somewhere inside the brain,
Yeah.
right? So that if you've never thought of that before, you've never even had that conception before, and your brain, it's in your brain at this moment, there's some neurons there that are firing it. And if
Okay.
you reinforce it over and over and over again, then all of a sudden that becomes a pathway that you're open to and dominating.
Okay. So, what makes this relevant to addiction?
Well, I think it's a lot of treating the emotional pain that comes from addiction and a lot of the relapse potential and things that we talk about in terms of building new plastic threads to help support post substance abuse, right? And the healing that goes on with that, and maybe it'll accelerate, the time in recovery and the time it takes for people to get better and stop living in that pattern of like continually in that dread or terror. I think it also enhances empathy and internal awareness, and so all those things are helpful in the long term potential of recovery, right? But the question for me always becomes: is this a shortcut?
Mm.
Is it a bypass to you doing the work?
Okay.
Right? So for me, right? So here's the way that it works for me and the work, right? Is that you go in, you get a new idea in your brain, right? And that way you get a like you do your fourth step and you talk to your sponsor about it and you do your fifth step and your sponsor has you see it in a different way, right? Like, oh, like I'm a really shitty person. Like I stole this, I stole that. Okay, so here's one of the things, right? I for the longest time had guilt about stealing money when I was like a little kid, and I was like I should make amends, right? And my sponsor was like, no, you don't owe that person any amends because they did this, 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 and you should have never been in that situation as a kid at 14 years old. And I was like, I'd never thought about it that way. But as soon as he said that, I was able to let go of that particular idea,
Okay.
right? And so, how did it shift so quickly? How was I able to let go of something that I'd held on to for so long with that particular act?
Okay. And so then every time you thought about that again, it just reinforced it and you felt better about it.
So at that particular instance is that I never thought about that again. I mean, until I like talked to you about it,
Okay.
or I use that as an example of having let go of something in an instant.
Okay.
Like the letting go process is just a dramatic frame shift in the way that you're thinking about a particular thing,
Okay.
right? But if I get a new idea in my head, let me think about what the new idea was. Going on vacation and it's okay not to drink on vacation or at the airport, right? That was unheard of for me.
Mm-hmm.
Like, what? You can get on a plane and not have a drink? And so once I heard that somebody else did it, and here's what they did to not want to get a drink. They had all these tactics and these skills that they had built up over time. And so they told me about these tactics and these skills, and I was like, okay, I'm gonna start implementing that every time I fly.
Mm-hmm.
And so when the stewardess would come by and they're like, "Hey, would you like to drink?" I'd be like, "Sorry, I'm an alcoholic." Right? That was my first mo. Like when I first got on the plane, my first like 5 flights, right? Because I was so worried about someone offering me a drink on the plane. Like I
Yeah.
wasn't gonna be able to say no, and I was just like, they said if I just tell them I'm an alcoholic, right, they will be like, okay.
Okay. Yeah.
And then I was like, I mean, I told like I was the very first flight that I had was I was flying to my brother's wedding in LA.
Mm-hmm.
And I got onto that flight and I was like, how am I going to stay sober through this wedding? Like all my college friends were going to be there. Like he had started living with my a really good friend of mine from college, and he was living there. I was going to see a whole bunch of my old friends, and I was just like, I don't, no idea how I'm going to stay sober through this whole thing, right? Like, it's just there's no way. There's no way it's going to happen. And I told them I was like, hey, I'm an alcoholic. I don't want anything to drink. And she just looked at me weird. But then I felt better about it. And so it was, what are the tactics that you're using to like not drink at this particular time? And then for me, the repetitive cycle of every time I got on the plane. So I've been on like maybe 50 flights since I sobered up,
Okay.
right? But every single time I did it, it was like now it's no big deal.
Yeah.
Now it's like no big deal to go to an airport and like not worry about drinking.
Mm-hmm. Okay. So how did the first psychedelic wave collapse?
This was back in this was back in the 60s, right? And so they were having a lot of backlash and a lot of fear because there was no clinical oversight going on. So there was a lot of promise back then too, but people were abusing it. There was a lot of political regulations that was halting the scientific exploration of this. There was like, you can't do that, right? And there was like around the marijuana time.
Yeah, it was all a lot of propaganda too.
Yeah, a whole bunch of propaganda, right? And you're like, you're gonna get addicted. This is gonna cause like our entire youth to like.
Have you ever seen Reefer Madness?
I've seen episodes or like seen parts of it. I haven't
Yeah.
seen the whole thing. But I
It's
mean that's around that time, right?
yeah.
Like that's what they were so worried about. And there was a lot of cultural stigma around the psychedelics, and they were like labeled as dangerous. And so a lot of the things was that you have to like see where society is at that point in time,
Mm-hmm.
in terms of like, is it going to be accepted? Is it time for that now? And I think for the last 60 years or so, it was like, no, we're not doing that until
Yeah.
there was a resurgence and there was new interest in all that stuff.
It's funny too because of the climate and the environment that we live in today. Drug use is okay, almost. You know.
Yeah, it's like it's not criminalized anymore.
Yeah.
And so you're looking at the legalization of marijuana. I think that had a lot to do with it.
Mm-hmm.
Where you're like, well, you're decriminalizing all of this stuff. What about this stuff that has therapeutic value too? Because one of the main pushes in California, at least, for medical marijuana, or like the very first break
Mm-hmm.
was in, I think it was like early 2000,
Yeah,
right?
two
Where they
thousand
had where they
four.
had all of the, I need to get a prescription for this, right? It's for my glaucoma, for my chronic pain. And
Yeah.
so if that was starting to be okay, then why not these other substances, right?
Yeah.
That have more of a therapeutic potential than the marijuana did.
Mm-hmm.
And so that became almost okay to start looking at these things.
Yeah. So, what what are the what are the biggest misconceptions around psychedelics? You think?
I think that it's like it's habit forming. It causes a lot of it's a shortcut, right? And you do it once and you're gonna find nirvana and you're gonna be walking on a cloud the entire time and it's gonna fix everything. And I don't think that that's how it works, because I think it's a tool to get you into a particular state that then helps you integrate in the stuff that you're going through. And so it's not just taking the drug. It's not like taking the drug at a club, getting it, going into a K hole, and then being like, "Oh, I found the solution to all my trauma problems." It's
Mm-hmm.
like actually doing the work with the therapist and integrating it, all that stuff. It's also the idea that like natural does not mean safe. So a lot of people are doing like ayahuasca or like mushrooms, and they're like, "Oh, like it's from nature. It's
Mm-hmm.
totally fine." And that's just not the case at all. Um, a lot of the other stuff is like, if I use this, is it a shortcut to doing my recovery work? And so for me, like, it's not a I did ketamine and I got better, that I don't need to go do all this other stuff,
Mm-hmm.
right? I still need you to go do the other stuff.
Yeah.
Building community, because that's for me what reinforces those pathways. So if the ketamine gave you a new prefrontal pathway, what are you going to do? What are you doing to reinforce it over and over and over again? So it's not just that one and done type of thing.
Yeah. So how do psychedelics alter consciousness?
Okay, so they disrupt the default mode network, which essentially is the global connectivity patterns between how we're doing, like how we're experiencing reality. And so it blurs the boundary between self and the environment. So the default network is what goes on when you are not paying attention to the outside world. It's like what's going on inside of your inner world.
Okay.
And then activates a whole bunch of emotional and memory regions that you wouldn't necessarily have access to before. And then this promotes insight and perceptual flexibility, which is then like the, I guess, fertile ground for reframing ideas, or reframing things that are coming up for you.
Okay. So why is this era called like the psychedelic renaissance?
Well, I mean, it hasn't been around for like 40 or 50 years, right? And so like now there's all this money and all this attention and all this research going into how can we help patients that are suffering from long-term trauma heal from these particular things. It's a lot of like research institutions are going in and looking at, hey, like what can we do? How are we building these randomized controlled trials to actually prove that this is working? And then there's a larger and larger acceptance in the medical field that like, hey, this is a potential modality that could be good. I have some of my I have some I'm somewhat skeptical of it because it's all cash pay right now. Like it's not really covered by insurance companies.
Mm-hmm.
And so I always get a little skittish, right? When someone's like, dude, we're opening up a ketamine clinic. And you're like, what are you doing at this clinic? And they're like, we're infusing ketamine. And I'm like, and they're like, we're infusing ketamine, and they have these amazing like shifts and like, is there a therapist involved in this? They're like, no, we have them do a questionnaire beforehand, and then we have them do a questionnaire afterwards. And I'm like, so it's not guided. And I'm like, who do you see for therapy? They're like, oh, it's just the medication. So like, I get really squeamish about that and not having it integrated in with a larger picture
Mm-hmm.
of like, here's long-term healing. Here's what long-term healing looks like, and putting too much emphasis on the medication and not
Yeah.
enough emphasis on the actual like process of change.
So when it, especially as it relates to addiction, and so there's a lot of people. I mean, the spectrum of people that are accessing this kind of care. It's it's like the stay-at-home mom that doesn't have addiction problems to
Mm-hmm.
like the hardcore alcoholic and addict to the PTSD suffering vets. Like it's everybody. A lot
Mm-hmm.
of people are accessing this stuff. The thing that I am always like that I think about all the time is like the addict or alcoholic who have already kind of geared our brains for something specific as far as around substance goes, at least. Is it going to actually have the same therapeutic value for us, or is it not because of what we've done to our pathways?
And I mean, this goes back to the what they would say in the rooms, right? If there was a cure for alcoholism, I'd want two,
Yeah.
right? If there was a pill for that, I'd want to see if two was better. If one
Mm-hmm.
was great, right, two is probably better. And I think that's a lot of the things that go on with some of the things that they're taking is like, well, that had a really good effect,
Mm-hmm.
right? I mean, you're looking at ketamine, and what you're trying to do, and we'll get into this, is that you're not trying to get the anesthetic approach. You're trying to get the dissociative effect from it.
Mm.
But that dissociative effect is a very
Small
small
window.
therapeutic window
Mm-hmm.
before it goes into the anesthesia side of it. So if you're abusing it, right, you're not getting the dissociative. I mean, you're getting it at the beginning, but then you overshoot it, and then you get the anesthesia side of it.
Mm-hmm.
So then you're mixing like ketamine with like MDMA, and then you're just in this K hole, right? And like, how much therapeutic
Value
value are
of
you
that,
getting it at
yeah.
that point?
So when you talk about, can we say like the names of drugs on this?
What do you mean?
Can we like name an actual product?
Uh, I don't know.
So there's the
Why don't you name it? Oh, okay.
okay. So there's
So,
the inhalant one.
there's so what we can say is there's different modalities for administration,
Okay. So
right?
I think one of the most common ones is the like the nasal inhalant one.
Okay.
And people are like taking the stuff home too. It isn't like
Yeah.
it isn't just you go, you get your therapy, week 4 you then dose and you sit with the therapist. Oh, people are like taking the stuff home.
Right. But I don't know how much is actually in that.
So that's what I was gonna ask
Right. I
is
don't I don't think that there is that much inside of the nasal spray, or like the concentration of that.
mhm,
I mean, when I think about like abuse potential, I was thinking about like Matthew Perry, and like what he was doing, right? And he was doing, from what I read, was he was taking like vials and vials and vials of it and injecting them intramuscularly into him,
Yeah.
right? And so that's completely different than a nasal spray. The nasal spray like is a much lower concentration.
Yeah, for sure. So uh, when I was introduced to ketamine, that's how we were doing it. Is we were going to TJ, getting vials
Okay.
of it and using it like that.
And just
Hmm.
putting it in. Yeah.
And it wasn't. There was nothing therapeutic about it. We always ended up on my roof, like just stuck.
What do you mean stuck?
So so it was like tunnel vision,
Okay.
and it was almost like scary to move. Right? It felt like a gravitational shift had happened,
Okay.
and like we would just end up like outside on my roof, just laying on the roof, and just
And
like
you wouldn't go anywhere. You would
wouldn't
just lay
move
there.
for
I mean,
hours.
I would see that in my raving days, and I was like, "What's up with that guy?" They were like, "Oh, he's in a K hole right now," and I
Mm-hmm.
was like, "What is that?" They're like, then this was when I was like 22, and they're like, "Yeah, he took ketamine," and I was like, "The horse tranquilizer? Like, why would anyone want to do that? Like, that sounds crazy, right?"
Mm-hmm.
And like, I never got into that because you just heard about. I was like, "Why would anyone want to take a horse tranquilizer like that?" That just didn't make sense to me, right?
Yeah.
I was like, "You can do ecstasy, that makes sense, right? But horse tranquilizer, that
Yeah.
doesn't really make any sense to me. I don't
Yeah.
understand why anyone would do that."
Yeah. And when I look back on it, when I made a lot of dumb decisions around drugs. um.
I
Uh,
think I think I made I mean, I definitely made dumb decisions, but I was aware enough to know that my personality was addictive enough that certain drugs were a very bad idea
okay.
because
So
I would probably like them too much.
yeah, my whole thing. Remember, like after I had already done all my science class experimenting,
Uh huh.
uh, after prison, after like all that stuff, is when I realized I was an addict. There was no self awareness around this stuff, and I'd been using drugs for 7 years by then.
Okay.
So there was no like, oh, I should stay away from that. It was like, oh, that's better. Oh yeah,
I think
definitely need
I,
that.
I, I want to thank Nancy Reagan for all of that, right? Because I definitely
Mm,
grew up in the era
yeah,
of
just say
this
no.
is your brain on drugs, and I distinctly remember those commercials.
Yeah, the egg cracking.
Yeah, the egg cracking, and then, I mean, I think my entire generation was like fearful of a whole bunch of drugs, and so we were like, "Oh, we're not doing that."
Yeah, definitely, and that's like the generation ahead of mine, which you're on like the tail end of.
Yeah,
um, is where my parents were. And it was like all drugs are bad. They're all the same.
yeah, yep,
And
yep,
then I
yep.
tried one and I was like, this shit's great. Wait, I thought
they
are they all really the same?
they were must be all wrong, but I guess you probably get indoctrinated around that time, right? Because I grew up in my I grew up in the 80s, right?
Yeah,
In
I grew
like
up in
the
the
reg,
90s. It
yeah,
started to be that like rejection of that.
yeah.
So,
Yeah, I mean, I grew up with Ronald Reagan and Nancy Reagan, right? Just say no, and then you grew up with Bill Clinton
mhm.
and like the pot smoking
Mhm.
saxophone.
Yeah.
Yeah, completely different messaging.
I didn't have sexual relations with that woman.
Yeah,
Yeah. Okay, so what are the main clinical applications for what are we specifically talking about right now? Ketamine or MDMA?
yeah. So let's talk about let's. So I think we're gonna do let's do one at a time.
Yeah.
Okay, so let's jump into ketamine
Okay.
first, and then we can just talk about like how ketamine acts biologically. And it basically works on the NMDA receptor as an antagonist, which modifies the way that glutamate is firing, and so it has certain effects at certain dosages. At like lower dosages, it has this, dissociative, euphoric effect. And then at much higher doses, it has an anesthetic
Mhm.
effect, right? And they use it for anesthesia all the time.
Mhm.
And what happens at the lower dosage during the euphoric stages, that it produces a state in which you can have generations of a lot of neuroplastic pathways all at once because there's a factor called brain derived nootropic factor,
Mhm.
which allows for a building of new prefrontal pathways and emotional balance between the prefrontal cortex and the amygdala, allowing for you to have more and more emotional control, right? So, what we talk about with our work is that that's what we're trying to do when I give
Mm-hmm.
you like the Depakote resets and like the oxcarbazepine and all of that stuff. They're doing it on a much more targeted level
Mm-hmm.
and a much more like intense experience, right? And so this increase in neuroplasticity, right, occurs within hours or minutes of that dosing.
Really?
Yeah, and so there's a huge possibility of like profound effects really early on, but critics talk about how that effect fades without therapy. And so this goes back to the idea that, oh, what did you really quiet down? Did you quiet down the fear that was going on? Did you quiet down the it's like it's when they talk about it, it works for depression, right? We've talked about this before.
Mm-hmm.
Like what is depression? Is depression the negative racing thoughts? Or is depression like really a state in which you can't like you have none of the neurotransmitters that are firing? Like in a true depressed state.
Yeah.
And what is this actually working on?
So somebody just asked right now thoughts on 7 hydroxy, and
Okay.
we didn't do this one live, and so this is gonna be coming out soon. But whoever asked that, what is your name? Whoever asked that, first of all, because it just says fun. But we have an episode on 7 hydroxy and kratom that's coming out
And a couple.
in a
What's
couple.
that? What's their question?
It just says thoughts on 7 hydroxy. So what
I
are your thoughts?
just I just had a patient who was a patient of mine from clinic who was like, I just tried it. Like she showed me the packaging. It was all in bright colors, neon things, and she got up to like 390 milligrams and could not get off of it. She was having like the restless leg, the cramping, the diarrhea. Like it was bad for her. And I see this over and over and over again. If you are taking kratom and you form a dependency on it, I just want you to know that it is so hard to come off of, especially the 7 hydroxy because of the huge amount of dopamine that gets released whenever you take it, that you end up with a restless leg experience that makes it so uncomfortable that people just don't come off of it. They just
Yeah,
stay on it. I would not recommend it at all.
yeah. I'd be interested to whoever asked that. What is your name? And I'd be interested
And
to
how
know
many milligrams are you taking,
how many
right?
milligrams are you
And
taking?
if you're taking a ton, you should probably call Chuck.
Yeah, for sure.
We'll call Chuck and we'll get you in.
Okay, so why is ketamine significant for addiction treatment?
And so it's being used for the treatment of severe depression and acute suicidality, right? So, but it also has applications for PTSD and trauma-related mood disorders. It has some effect for chronic pain, but for a lot of it, right, it helps reduce the cravings for alcohol. And a lot of the uses that it has, right, it's rapidly expanding because they're using it for off-label things
Mm-hmm.
a lot, right? The reason that's so good for addiction treatment is that it reduces post-acute withdrawal dysphoria, right? And it restores some of the emotional connections that are going on, and it interrupts the rumination and the cravings and like the negative racing thoughts. But we talk about this too,
Mm-hmm.
right? Like that's what we're watching out for. Like the more and more that I look into ketamine, the more and more I think it disrupts the thing that we're looking at
Mm-hmm.
and the escalation that we're looking at. So when they get into the negative racing thoughts phase, and that's a persistent state, it helps to interrupt that.
Okay.
So for some people, right, they just stay in that state all the time.
Mm-hmm.
That's what I think. That's what I think the refractory depression or treatment resistance depression is when they get into that state and they can't actually come out of it. It doesn't go away.
How long can that persist for?
From what we're doing in the model that we're looking at, 5 to 7 days. But imagine if you were in that state for a month, 2 months, three
Yeah.
months, and it just didn't stop, right? And it was the central medial amygdala that was firing all the time. And so you're in that constant state of fear and dread and terror, and not in the upside with the motivation with the basolateral amygdala, but you were just stuck in the central medial amygdala. That sounds awful,
Yeah, it sounds
right?
terrible. And I think that we see this with people, right? We see it in patients and clients that have major depression.
Yeah. And I think that that is so when we were at the Menninger Gala, and then we
Mm-hmm.
talked about the targeted TMS, like
Mm-hmm.
I did a lot of research into that,
Really?
and what it was when they were targeting it, right? It was that pathway.
Really?
It's targeting the amygdala. It's targeting the prefrontal pathway, and it's giving you a whole bunch of like magnetic pulses and things in that particular area, trying to reset it. Well, I was like, that's amazing, right?
Yeah.
That's exactly what we're doing with the resets that we do.
Okay.
Um, yeah. So I mean, I think a lot of the stuff that we're working on, a lot of stuff that we'll be seeing in some of the things that we're doing, all kind of come back to the same idea, right? And that this is a better model than we've had before.
Yeah. I would be very surprised if this didn't work out. Um, I just don't see there being like a situation where what we are doing fails, because what we're actually saying, like really what we're actually saying is we're addressing the biological and then conjoining it to the spiritual and emotional and mental
Yeah.
component that's pretty well covered.
Yeah. So let me just give you the biological explanation for why this all works so well.
Hmm.
Yeah.
Okay, so what are the key controversies when it comes to ketamine?
Okay. So let's go over the dosing and the delivery methods,
Oh
right?
yeah, yeah.
Okay. And
So
so
yeah, let's go over that.
because that's important to look at, right? Because there's a bunch of different ways that you can take the ketamine. So there's the infusions that occur, and what they typically do is that you go into like an infusion center, and they will dose you with like zero point 0.5 micrograms per kilogram over the course of like 2 hours. So you just sit there, and they'll do a slow infusion into your system, right?
On a drip.
On a drip, right?
Okay.
You can do it IM, which what you were talking about before, right?
Yeah.
Intramuscularly, intranasally is also available. You can do lozenges. Have
Mm-hmm.
you seen those at-home kits?
Mm-hmm.
Yeah, like I just that
It's crazy to me.
that, but I don't know how much ketamine you're actually getting in those dosings,
Yeah, but the
right?
thing is,
And
and
then
this is
can you just take all the tablets at
that's what I
once?
was gonna say is this is the self-dosing part
Right.
of Suboxone that bothers me
Yeah.
is what's gonna stop you?
Well, I mean, you're an addict and alcoholic, right?
Yeah.
Like you're just gonna want more.
Mm-hmm.
I don't know. Maybe it's great for the
Non.
average, the non-addict, the non-alcoholic who is like, I've got depression, right, and
Mm-hmm.
is not going to abuse it. But that's not my world, right? Like the world that I exist in is like the world of addicts and alcoholics, and if you can abuse it, it will be abused,
Yeah, for sure.
right? And so it's are you getting the psychedelic effects from it or the sub anesthetic effects from it? Like what is it that you're actually trying to get to help make it useful, right? And so then there's all sorts of controversies around this, right? And we kind of touched on a couple of those in terms of like what are like you're getting ketamine mills,
Mm-hmm.
right? Where they're prioritizing like, hey, like it's going to cost you, it's not cheap. It's like $600 or $700 cash,
Yeah.
right? To come in and do an infusion. Like what are you getting for that, right? Are you just getting, we're going to give you 10 treatments of this based upon this protocol? Like I don't know. And for me, when profits take precedence over patient care, that becomes a little bit questionable,
Oh. Uh-huh.
right? I start to get leery of that,
Mm-hmm.
especially if there's money to be made, right? Like, I was shocked when I started watching those documentaries on the doctors that would give out scripts in like
Oxys.
in the pill mills in like
Florida.
Florida and Louisiana, and I was just like, who does that? Like, how is that even? And then just making money hand over fist,
Mm-hmm.
right? And I was like, it was all cash. It was just, it's insane,
Mm-hmm.
right? But I mean,
And there's no centralized system.
right, for
That's
tracking into that,
probably true for this too.
yeah.
Um,
I think the DA has gotten a lot better about that, but it may not be on their radar,
yeah,
right? As like the thing to like watch out for.
I think a rule of thumb around drugs, historically this has been true, is there are no rules until they need the rule,
Yeah.
and then they make it.
Yep.
There's almost like no safeguards when it comes to
Yeah.
the introduction of a drug and its distribution.
And a lot of the stuff that's going on right now is that after COVID, we started doing a lot more telehealth.
Mm-hmm.
And so a lot of the telehealth stuff is like, well, do you really, how well do you know the person that you're doing that thing with after a 15-minute consultation? You're like,
Yeah.
okay, great. We should give you some ketamine, right? And you met the person online and they're doing these like voice calls. Like, it's just, it doesn't fit into the way that I would practice medicine,
Yeah.
right? And then patients tend to develop a psychological dependency on it. And then clinics are using non-clinicians as guides, right? Like, is it really regulated? Do you have a therapist that's there? Is a therapist licensed for this? Like, it's just, I don't know how regulated this entire thing is, right? And so that's where the problems come in. And there's a lot of risks to taking ketamine too, right?
Yeah.
It's not a benign drug. It's
Mm-hmm.
not one that you can just be like, oh, like it'll be fine. Like there's dizziness, nausea. It's common. It elevates blood pressure on occasion. Sometimes drops blood pressure.
Uh-huh.
There's a lot of emotional sensitivity post session, and then a dissociative pain may trigger a manic episode
Yeah, for
or a
sure.
trauma response. Right? There's a lot of people get cognitive fog around that, and so it's. I mean, it just goes back to like Matthew Perry and like him passing away in a hot tub. Like, was it because he was in the hot tub? Was it because he took this box out? Was it the kind, or was it all of it at once? Right?
Mm-hmm.
And it's just not. It's not a great situation to be in. I mean, I've known a couple of people that have passed away around the same time that they were taking the ketamine,
Really?
right? And so, but they didn't associate it with that, right? Or it was like, did they
Yeah.
die of that? I don't know. Like what? I
Yeah,
don't know.
yeah, yeah. I mean, it's kind of like that whole thing that happened around the pandemic, where when people died, they would attribute it to COVID, even if it was a heart attack.
Yeah,
Like if the guy had COVID in his system, but he had a heart attack, they said that he died of a COVID.
COVID. Yeah.
Um, okay, so what defines ethical ketamine practice?
I think for me, right, and this is just for me,
Mm-hmm.
is that it's trauma informed. Um, and so you're making sure that you are treating patients that, and they're aware, and you're aware of what their trauma stuff is, and you're aware that they've gone through a bunch of like, diagnostic and therapeutic things to be like, okay, like you meet the criteria for this. And so it's not just coming into a clinic and be like, hey, I think I want to start taking some ketamine today, right? Or I think I want to do this. And I think for me, it's a two-phase model. One where you're getting the experience of the ketamine itself, but then you're integrating the stuff that you learn during those states. And it's having key transparency and expectations around, how many follow-up sessions do you have, and then a collaboration between the provider who's doing the cognitive behavioral stuff and the person who's actually prescribing the ketamine. And a huge emphasis on safety and aftercare, right? It's not like a one and done thing or like, hey, here's the course of like these three things. Like I don't see anyone in clinic who doesn't have a therapist or isn't in some type of recovery community.
Yeah.
Because for me, it's all about like I can help you only so far, but your job is to build those prefrontal pathways and to integrate those things.
And this really comes back to we can point at Matt and say like, what about the T, right?
Yeah,
And it isn't even like you're in clinic, you're not using narcotics ever, right? And
mm-mm.
you still have an emphasis on the community, on the recovery community, not
Yeah,
just your support group, but the recovery community, and then additionally the clinical aspect of what's going on as well.
right.
I think that we're about to move into like an era for recovery treatment where that is going to really start being the backbone more of around like because we're seeing like the downstream effects of these suboxone clinics that are
Mm,
suboxone clinics, that's it.
that's it. Yeah,
And then we can kind of look back on like what happened with methadone and like all of these different treatments,
right.
and it was like okay, the real foundational piece around the therapy or the treatment is what's going to allow this to be foundational.
Yep.
So what does long-term research reveal regarding ketamine?
Regarding ketamine is that there is a substantial relief for depression in some cases, but that relapse occurs and the patients fall back into depressive states without the therapeutic framework. And so this goes back to, did it quiet down the amygdala? And that's why it worked initially, but then you didn't do any of the work around it to
Mm-hmm.
keep it quiet. And it's the building of the prefrontal pathways. There's a potential, like obviously, for quick tolerance to build, and then with patients wanting to get more and more frequent dosing because they're not actually building those prefrontal pathways.
Okay.
They're only doing it to quiet down the amygdala. Um, And there is a lot of, investigation underneath, like how effective is the cognitive behavioral therapy around that, like what needs to be guided in the therapeutic process, what type of psychotherapy is most effective, what modalities are most effective, instead of just being like, to go in and talk to the person, right? Have a therapist and you're just going to talk to. Well, what is it that you need to be doing in those therapy sessions that allows for consistent change to occur? Because a lot of the therapy is individualized, right? You
Right,
don't know what
right.
that person needs. So how do you standardize that, and how do you treat that in a randomized controlled trial? Because each provider is different, each
Yeah.
therapist is different. So
So
you can't really say, it works because we did this particular modality, right? Because that modality changes from provider to provider.
so years ago, and I can't remember if this is correct or not, but years ago I had heard that they were doing like group sessions, like in the VA with MDMA.
I
And I,
think I, from what I, so you want to jump into MDA and MDMA now?
yeah, yeah, yeah.
Okay. So what I heard about the MDMA was that it was required to have two prescribers present, and that was a safety thing. So it
Yeah.
wasn't like group therapy. It was like you couldn't just do it with one provider. And the stories that I'd heard about that was because ketamine allows for like a very like internalized process to happen, whereas MDMA is all about the external connection with somebody else, and like the oxytocin release and all of those
Yeah.
things, and that there was a lot of abuse potential with patients around that time. And so you had to have two providers in there at once, so that made it less likely to happen.
Okay, so that was one of the parameters that they needed to strengthen around. It was the proprietary, um, like blockers that they were like, there's too much chance for inappropriate interactions between the client and the provider.
Yes.
And so that was one. It wasn't the efficacy. It wasn't whether or not this was effective. It wasn't
Yeah.
this isn't. It needs to be developed more. They were like, no, there needs to be greater safeguards around the administration of the drug.
Right, and the safety of the patient.
Mm-hmm.
Yep, because that was the weakest link was the provider offering that care.
Right.
Yeah.
Okay. So how does MDMA affect neurochemistry?
So I've done a lot of research on this, right? So I've told you that that was like my drug of choice,
Yeah.
right? Like that was, if I could go back and like do one, it was that one. And so MDMA increases serotonin, dopamine, and oxytocin release, right? But it's the flood of serotonin into the system that probably has the most effect on the brain. And it lowers the amygdala hyperactivity and the fear reduction, enhances trust and emotional processing, and helps facilitate trauma recall without you being in a state of panic. And so, what they're doing is that they're bringing up trauma events with a patient while they're in these particular states. So it's not like just going out to a rave and like listening to music, right? It's like, okay, you're in this very susceptible state right now. Let's talk about the things that you were kind of like stuffing away, right? Like, let's bring those particular things up. And what's created is this sense of like empathy, connectedness, and that talking about it creates lasting change.
Okay. So what are its strongest clinical outcomes?
So they've done a bunch of trials on
Yeah.
this, right? Which showed that there was a lot of remission with the PTSD, with patients that came in with symptoms of that, and it reduced the avoidance and emotional numbing that they were having to do when they were actually able to talk about this.
Mm-hmm.
It fostered forgiveness, self compassion, and a strong therapeutic alliance that was formed by the provider and the person that was undergoing that process, right? But that's where the concerns started to come in, right? And there were concerns over therapists' over involvement in the patients and
Mm-hmm.
like the lack of boundaries that were happening because you were in such a state.
Mm-hmm.
Yeah.
Yeah, that's an interesting thing to think about for me because did I tell you about my? I had a therapist that tried to diagnose me with something that her husband had and then work through whatever
Uh,
the. Oh, dude, it was crazy. So yeah, I definitely understand the.
well, but I mean, I think about the state that I was in when I was like on it,
Oh
right?
yeah,
Like, all I wanted to do was like go around and like dance
love
around and
people.
love people and like have my hand massage and like that was it. That's all I wanted, right? I
Yeah.
wanted nothing more than that, just to like run around and like be happy. And so like being in that particular state by someone that is less than nurturing or kind could be problematic.
Oh, there's that too. Yeah.
Yeah.
My assumption around it was that there was like too many chances for inappropriate like contact.
Yeah, and I think that's what the concern is, and that's
Hmm.
why there's always two providers available,
Okay.
right? Especially to someone who's traumatized and emotionally vulnerable at that time.
Okay.
Yeah.
So why is MDMA relevant to addiction?
So, I mean, we talk about addiction being an attachment disorder, and
Hmm.
so the use of MDMA helps build connection and intimacy, alleviates a lot of the shame-based triggers, so it allows for them to have a process by which they can start talking about the things that they hold, and the shame that's like within all of that. And so by having a compassionate lens and a compassionate provider, they can actually look at their trauma in a compassionate way. Um, I think one of the biggest critics of that particular thing are also, well, you're building this therapeutic alliance and this like empathy from this provider. How much of that gets transferred over after the sessions are completed? And so that's where the potential for the abuse comes in,
Hmm.
right? Is because you're in this connected state with your provider. That's why having two providers there at the same time mitigates that.
Do you know how, like, what is the structure? Is there one that's primarily doing the therapy and the other one is just observing,
So now they're both doing it at the same
participating?
time. Yeah.
Okay.
So that you're not attaching to any one of them. It's both.
Okay.
Yeah.
So, what are the ethical issues around
Right.
MDMA
It's we
therapy?
keep talking about this, right? It's the
Yeah.
boundary violations and the boundary violations that occur when you're in that particular state. So there's a lot of scandals, right, around damaged trust that have occurred. I mean, you can go online and start looking and
Really?
being like, oh, and significant boundary violations, like the kind that get you your license revoked
Right. So, specifically with MDMA.
with MDMA, yeah, or like
Okay.
therapists that were doing that. And so then the question becomes: are you getting a spiritual awakening from this, or are you just in a very suggestive state?
Yeah.
And that suggestive state is where the abuse kind of comes into play.
So, when we're talking about specifically the MDMA, right? I feel like it's different a little bit with ketamine. I feel like it's really different with
Psilocybin,
psilocybin.
yeah.
But I don't see how this is going to apply effectively to addiction treatment for MDMA.
I think that if you're working through your trauma and you have shame around certain things that you haven't been able to talk about before, being able to talk about that in a state where you are more willing to do that particular work, where you feel safe, you feel connected, and actually touching on those things to actually start building those prefrontal pathways.
Okay.
The things I never wanted to talk about, the things I always like pretending like, oh, that's not going to be a big issue or that's not
Yeah.
a big deal, right? All of a sudden, I am able to talk about it and touch on it, which then builds that first pathway, and then that's where the opening comes in. But it's really important to have trauma informed people that know what they're doing, and so I mean, it's always how experienced are the providers that you're going to, like
Yeah.
how long have they been doing it for, like I mean, if I'm going to do my EMDR, like I don't want someone that just graduated from like the thing and I'm like their second patient.
Yeah.
Like it's the same thing with like the neurosurgeon, right? Like they go through this like intense training thing and they're monitored and they're like doing their work underneath a physician for like 7 years so that when they go start practicing on their own, it's not their first time. I don't know how much of that is regulated in the EMDR space.
MDMA.
No, the EMDR, like the
Oh, I've always heard. Well, I told you like that. People kind of like thumb their nose at EMDR.
I'm a big proponent of that.
Yeah.
Yeah, that's what. Well, I mean, especially around the experience that I had.
Mm-hmm.
But I mean, I went to someone that was in the field for decades, right? And
Yeah.
I was really trusted, so I felt safe in doing that work with her.
Um, okay. So, what physical risk exists with
Okay,
MDMA?
so uh, MDMA is a derivative of meth, right?
Mm-hmm.
And so there's a lot of like issues with not really knowing the state of your body that you're in, having the hyperthermia, the dehydration, the serotonin toxicity. There's cardiovascular strengths running around, dancing up a storm and like getting super hot. There's sleep disturbances, mood
Mm-hmm.
rebound is common, and you really shouldn't be taking any SSRIs, right, because of the serotonin like dump that happens with
Hmm.
that. You don't want to have a whole bunch of serotonin just running around inside of your system. Um, it's not medically approved yet or FDA approved yet, and so you have to get a special license to actually do the MDMA therapy. And
Hmm.
so they're only doing it inside of clinical trials.
Right. And we kind of talked about this, but around the who's got the money to pay for this stuff.
Right.
The coolest thing that I've so do you know who MAPS is?
Yeah. I don't know what it stands for, but I know that they're it's like the psychedelic research.
Yeah, it's the
Yeah.
multiple disciplinary application of psychedelic
Yeah.
studies. They are doing a ton of work with a lot of different things, but they had a big chapter of that whole organization at it was either USD or UCSD, um, and it's probably UCSD because they're
It's
medical
UCSD.
school,
Yeah. Yep.
but and, which is literally a 15-minute walk up the hill from a huge VA hospital.
Okay.
I mean, it's like right there. They might actually be on the same campus technically, but either way, they did a ton of work, and this started years ago, right? People were talking
Mm-hmm.
about this stuff years and years ago. Now, the lens that I look at all the MDMA stuff through is through my abuse.
That's how I look at it too,
Yeah,
right? So I'm like, what is that? Would that really work?
yeah,
But that's a big controversy around it, right? It's like you've changed a club drug into a therapeutic tool,
yeah,
right? So it's like, wait a minute, right? Like, how is this coming around full circle, right? And how is the FDA going to approve something that like for decades was underground and you'd see like kids rolling on Molly,
yeah,
and so there's a definite fear of they're trying to commercialize something that's actually a drug of abuse,
yeah,
right? And it's the debate goes on about is this really for profit or if it's is it for legitimate public benefit,
yeah.
right? What's the point of all of this?
It'll be interesting to see where we end up 10 years from now with this.
Yeah, no, for sure.
So, how does it compare to ketamine?
So we talked about this, right? Or I kind of loosely mentioned it before. Is that the MDMA fosters a sense of connection with other people,
Mm-hmm.
whereas the ketamine is more of an introspective, like internal thing that's going on, right? And so
Yeah,
you're looking at things from a let me how do I restructure things in my own brain versus how do I connect with someone and like have that empathy there that allows for me to like get the healing. And the MDMA stuff requires two trained facilitators. Those sessions are typically longer, right? The sessions that I've
yeah,
seen or like I've read about was that they were in there for like a few hours. But
yeah.
then that makes sense to me too, right? Because when I was doing ecstasy, right, that lasted for like hours and
Hours.
hours and
Mm-hmm.
hours and just being in that state. Um, and so there's a lot of emotional integration, slower recovery, and it's more relationally oriented than
Mm-hmm.
it is like internally oriented.
Yeah. So, the lens that I look at it through is through my abuse. And another thing that I always fail to remember around the clinical stuff is that they're basically microdosing this stuff.
Yeah,
It is not
it's
taking
not
5 pills in a night and like,
5 pills.
oh, dude, it was like my record was like 17 in a
I
weekend.
told I told you I told you what my thing was, right?
Yeah.
I wouldn't do more than one every 3 months.
Dude, it didn't, like, in my head, it's like, it doesn't sound effective in my
Well,
head.
in my head, here's how I was thinking about it, right? I was like, I'll do it once. I will get the perfect like amount from that one pill, and then I'll wait 3 months and build up my tryptophan stores again by eating a whole bunch of turkey and taking a whole bunch of supplements so that I get my serotonin stores back. And then I will do it again, but I'll only take one.
Yeah, within a few months of the beginning of that experiment,
Uh huh.
I ended up like in bed, like laying on my bed for like days after like weekends.
I think for me it was the fear of like it was like a squeezing an orange, right? And I was like, you can only squeeze it so often that the juice like runs out of it, right? So I don't want to squeeze it too often. I just want to let it plump back up and I'll squeeze it again. Plump back
Yeah.
up, let's squeeze it again. You
I
are of like the mentality of like, let me just squeeze every single drop I can out of it.
yeah. As a matter of fact, it wasn't just squeeze everything that I could out of it. It was like, how do we make it so that we can take even more?
Yeah,
You know, and then it was, and then we were like stacking other drugs on it, and it just turned into a mess.
yeah.
So what lessons does MDMA teach clinicians?
I think the key thing for that is that healing requires emotional safety and like good boundaries. And empathy can be something that allows for deep healing to occur. But I think that that's what you're getting when you go into the rooms.
Yeah.
I think that's what's happening when you are building those close, intimate connections and feeling very vulnerable with your support group. And this is just a way of like of hot wiring it. And so it goes back for me at least, right? Is to the idea that these are all shortcuts and that you can still achieve the same thing, but it takes time and it takes effort and it takes work,
Yeah.
right? But we live in a society where we're like, well, we want it right away.
Mm-hmm.
But what are the long term effects of that? I would propose that if you were revisiting your trauma and allowing for it to come up, but then you didn't have the safe space to go home to afterwards, that would be problematic.
Mm-hmm.
And so building a community and building an environment which you can do that work for me is like super important,
Yeah.
right? So like I would in the model that we're proposing, right, I would use it as like an adjunct. If we were to do this, right, let's say like 5 years down the road, it was like something that we were like, hey, like let's take a look at this.
Mm-hmm.
It would be, hey, how strong is your support group and how strong is your community? How many sponsees do you have? And let me get 2 or 3 letters from the people around you that are going to be aware that you're going to be doing this so that you have support around you when you go home. So that I'm not opening something up and then leaving you with that.
Yeah. Yeah. The thing about it, so when I think you can use like a wall analogy, right? Like if there's barriers to recovery, or like a fence, right?
Uh huh.
Historically, for me, like I'm running from somebody, it's always quicker to go over the fence than around the fence to get to the same place, right? And so, um, going around the fence definitely takes longer. It definitely you got to dodge more things. It's more work, right? Getting to the same place, like if you're jumping off the fence, to use the same analogy,
Mm-hmm.
there's a lot more danger to that landing and like a bunch
Yeah.
of stuff,
Yeah.
right?
And you're going over the barbed wires
Going
and
over the barbed wire, and
yeah.
it's like for me at least, for me in my recovery and the way that this would work is that I am such a dumpster, like a dumpster fire of an addict.
Mm-hmm.
I don't think it would be good for me to try to mess around with this stuff.
And I wouldn't like with my framework for recovery, right? This is not the first thing you try. This is the like, okay, you've done this, you've done this, you've done this, right? And when we talk about the multiple pathway approach,
Hmm.
right? You have to at least do this first, right? And then
Yeah,
once you've done this and you've built the community, great, let's go in and do some other work here, right?
yeah.
Like let's use these tools to hotwire this because you've built the community first.
Hmm.
I just don't know why people are so against it. I mean, I understand why, or like it's tough,
Yeah. So so I'm not against it. I'm against it for me. And
right?
ultimately, like the framework that I look through and really work with in my recovery and the way that I help other people is through the peer support model.
Mm-hmm.
And the bottom line of that is whatever works. Whatever's going to get you from being a degenerate, like low bottom
Yeah.
drug addict, alcoholic to a contributing healthy member of society.
I don't even need you to be healthy, officer. I just need you to be like
I mean,
better than you were before.
in your early recovery,
Yeah,
right? It
yeah,
is just better than before. But 5 years down the line, better than before, for me at least, isn't sufficient.
yeah. I mean, you have to continually evolve and get
Yeah.
better, right? Otherwise, you're gonna backslide down
Hmm.
the way. Yeah,
Okay, so we're gonna go into psilocybin.
yeah. I mean, this is like I'm gonna rely on you for this one.
Okay.
All right, in terms of like what it. I mean, I understand what it does. I just don't have very much experience with psilocybin at all,
Yeah.
right? Or like or how that works or how that functions because it's not. It's one. It was never something that I did in recreationally, right? I think I
Hmm.
did. I'm not sure what I did on New Year's, whether it was mushrooms or if it was acid. I was told it was mushrooms, but I'm pretty sure it was acid. It was like mushrooms laced with acid. So it wasn't real. So I really don't know what effects people are getting from it. So I think I'm going to learn something here, right? But I do know about the neurochemistry, right? And so it basically stimulates the serotonin receptors.
So this is how the psilocybin alters the brain.
Yeah,
Okay.
and then it goes back to the default network, right? And so the default network is that area in the brain that's most active when a person is not focused on the outside world. like working on your internal world.
Mm-hmm.
And so it works on that particular thing, and it enhances global connectivity and pattern recognition. So you're looking for the things that weave in together.
Yeah.
And so what they describe it as is like this ego, like delusion of the ego, or like
Yeah.
it
It
like
drops
melts
away.
away, and then you're just left with you,
Yeah.
right?
The
Or the
reality
essence
of
of
what it
you.
is. Yeah.
Yeah, I never understood that, right? But the question is that true healing, or is that like, are you in some altered state? Like what is that, right? What is it really, and what are we trying to target therapeutically?
Yeah. So, what are the main therapeutic targets when it comes to psilocybin?
So they've been using it for major depressive disorder,
Mm-hmm.
anxiety, OCD, and end of life treatment, right? I
Really?
Yeah. So like
That makes a lot of sense, actually.
having better meaning around what does it mean
Mm-hmm.
to have this? Yeah.
Yeah, because when you talk about the benefits, so first of all, there is no like therapeutic dose of psilocybin that
Yeah.
is also that produces like that has like hallucinogenic properties.
Okay.
A lot of it is the nootropic benefit,
Okay.
the amount of neuroplasticity and neuroplastic like potential or like neurogenesis potential for these because it's a nootropic, right? It's
Right.
so, but what I have heard around microdosing is that the benefits of it is it's equal to the amount of neuroplasticity, like the neurogenesis that happens from the age of like it was the age of 2 to 4 or something like that.
Oh, okay.
That
When your brain is like
mm-hmm,
all the mirror neurons are there and it's like super firing, and
mm-hmm,
you're integrating everything all at once.
yeah.
Okay, interesting.
And so they've done like scans around brains pre-treatment and post-treatment, and the electrical activity multiplies um, just after a single dose.
Okay. Interesting.
Yeah.
Well, I mean, so then that makes sense why they're using it for clustered headaches, right?
Oh,
And
really?
migraines, yeah. Or at least in the neurology side of it, like that's one of the potential applications for it.
Okay. So how does psilocybin aid recovery?
So I think it's all reframing, right? Reframing, like, what does it mean for me to have a craving? What is this drug doing for me? What is the point? What is the point of all of this?
Mm-hmm.
Why am I even doing any of this? And I think it enhances for some people gratitude and like gives them meaning around things. But I don't know what the long lasting change is, and I don't know how you put it into a therapeutic framework, right? Because I think it's really alone, right? Like I don't know. Like I don't know if people are doing mushrooms in a therapeutic setting, or
Mm-hmm.
if they are. Actually, I take that back. I do know that they're doing mushrooms in a therapeutic setting.
Like in Colorado and stuff.
Yeah. No.
Mm-hmm.
So it was really interesting. One of the girls
In
I went
Austin too, actually.
one of the girls that I went out with was like, yeah, my therapist recommended that I go do psilocybin, and I was doing it at this dude's house, and I was like, what? And they were like, yeah, it's not really something that it's like that is approved, but she recommended it, and so I
Yeah.
went and I did it, right? And it was just cash pay, and here it is. We'll take you on this trip, right?
Yeah.
But she found it to be very rewarding and very therapeutic for her.
Yeah, it's interesting. I have a friend in Colorado, um, and this person is like really connected to the community of people in Colorado that are there's companies around this,
Mm-hmm.
and there's like entire therapy like models that they've created around it, and
And they're coming down to Houston like illegally, or
no, they're up in Colorado.
okay.
Let me see. I wonder if I should even name this company. Either way, there's
We don't name companies.
yeah. So but people are getting massive effects from it. And the thing about it is, like, when you think about a therapeutic dose of psilocybin, there is no like, oh, I'm gonna take a heroic. I'm not doing grams of this
Uh
stuff.
huh.
You're literally microdosing, but the effects of it around addiction treatment, people are coming out of it much more able to cope um,
With like with their anxiety and
in a
their
healthy way.
stressors,
Yeah.
and that, but that's what it all boils down to, right? Addiction treatment and long-term recovery for me is just how are you handling your fear?
Yeah.
And if this is a modality that you can use that gives you better insight into it, then by all means, right? But I think the issue that's happening right now is that they're decriminalizing it ahead of any of the medical knowledge, right? Or like medical proof or efficacy of it, right? And there's a lot of like unlicensed retreat centers that are exploiting people that are heavily traumatized, and they're like, "Hey, come on down. We'll help cure you of this in a weekend," right? And so I don't know how much evidence there is to support the microdosing idea, right? Or what they're using it for, because a lot of times like they're using this as like sacred medicine
Yeah.
for microdosing. Like that's when I first heard of it.
Yeah.
I was like, what are they microdosing? They're like, oh, like it's part of the ceremony, and I was like,
Yeah. Yeah. A lot of it is framed around ceremonial
right,
use. Guess who just popped in?
who?
Mr. Buttermaker.
Oh, nice.
Yeah.
Okay,
He's our number one fan.
that's awesome.
Yeah. Okay. So what are the psychological risks of using psilocybin?
Yeah, and I think it's the reemergence of trauma, right, and the panic attacks that occur with it, and the possibility of psychosis, especially in some patients that might be predisposed to that. Um, Having a quote unquote bad trip,
Mm,
right, when you're not in a safe environment, may be very jarring for people, right, especially when you're flooded with memories or experiences that you really can't process or really can't understand.
mhm.
And if there's a failure in integration of that experience, I mean, that could destabilize somebody, especially in early sobriety.
Yeah.
Yeah.
Okay. So what distinguishes safe versus unsafe practices?
I think it's informed consent, knowing what you're getting yourself into,
Okay.
creating a safe space for it. Medical screening process. Does anyone have like any predisposing heart conditions that might lead to, problems if they get into a panic state? Is there a structured way in which it's being administered? Is there aftercare that's going on? Is there ways to integrate the process? Is there a therapeutic community? Like, there's so many things that need to happen to safeguard the experience than just it being about the drugs. And I
Yeah.
think I think if I want anyone to take anything away from all of this, right, is that these drugs are not meant to be done at home by yourself,
Mm-hmm.
right? It's going into the combination of the MAT, right? Medication assisted therapy,
Mm-hmm.
right? And so it's the treatment side of it and how important that is. Um, yeah, and I think a lot of the criticism, right, comes back from the idea that there is untrained providers or providers that aren't certified or people that are like, oh, dude, how much can you charge? Like
Yeah.
$800. Like that sounds awesome, right? Like I can do that.
Yeah. So this kind of like even charts into like the ayahuasca stuff.
Yeah.
Have you heard about single treatment episodes of ayahuasca price?
Mm-mm.
10 grand on average.
What? This
7
is
days
this is in
in Mexico.
Mexico. Okay.
Mm-hmm.
Oh, have I heard about that? What did I hear about? I think I did hear about some patients going down and getting ayahuasca in a detox setting
Mm-hmm.
and then them paying cash for it. I
Yeah.
actually I have heard of people going down to Mexico for that.
Yeah.
They came back to the detox after that, right?
Really?
Because they didn't take them off of anything. I think they said they were going to go down there and take them off of the opiates, and then they came back and they were like still on it.
Yeah.
And I was like, well, no, they were they were off the opiates, but they were on a shit ton of benzos. And I was like, what? Like, what did they do down there,
Oh,
right? What did you
wow.
spend your 10 grand for? And they're like, well, they're giving me benzos the entire time. And I was like, I have to detox you for this now.
Okay, so Amy in the house.
Amy, who?
It doesn't say last name.
Okay.
But Nate says he was prescribed ketamine for depression, but without any follow-up integration, just dosing in the doctor's office, and he would himself years later be unable to walk from ketamine. He's clean now. Good job. High
Okay.
five.
Awesome.
Um, so yeah, it just
They
goes
just
to
formed a
show.
dependency on it.
Mm-hmm.
Okay. That's so interesting.
Yeah, and so I'd be curious to ask, like, what was the dosing protocol that they gave you, and what did it end up being,
Right.
and how were you continually?
And I don't know how much standardization there is around that yet,
Yeah,
right? Because it varied. The stuff that I was reading about, it varied between like you could do it once a week, you could do it twice a week, you could do it once a month. You could like the intervals didn't make sense as to why they were
yeah.
doing it
I've also
the way
heard
that they were doing it.
I've also heard stories around specifically the inhalant, like the nasal inhalant, where they were dosing daily, multiple times a day.
Hmm. Daily, multiple times a day
Mm-hmm.
in like IV.
No, with the inhalant.
They handle it. Yeah. I mean the whole idea of like let me mail order this and like give you a bunch of ketamine and then have like audio things and have you write down experiences. Like
Yeah,
it just I was like, what? Like you're gonna leave it to some guy to like work through his own trauma himself? Like it
yeah,
just like the therapeutic alliance for me is so important to have like someone who's experienced and like has gone through it before and like is working on those things. Um I just I don't know how that's possible, right? And then that goes back to the whole like how effective could that possibly be,
yeah.
right?
I mean, it's kind of what he was just saying, is that like there was no follow up integration, right? And
Right.
he just kind of had it. The thing about it is, when I was in treatment the last time, I then went into a step down, and there was a person there for ketamine, and the journey that this person went on around um, getting off of it sounded like a nightmare.
Okay. How long were they on it for?
A couple of years,
Okay.
yeah, and young person too, but just came from a really affluent family, and like just kind of, he's an addict ultimately, and so
Yeah.
I can imagine, like, if that was a thing when I was a kid and I found out, like, oh, I could like manipulate this thing and my
Yeah.
parents will
And
pay for it and
yep,
it's
yep,
okay.
yep.
Yeah. So how is ayahuasca used therapeutically?
Okay. So ayahuasca, it's DMT,
Mm-hmm.
and the MAOI,
Yeah.
induction and brewing visions and stuff like that.
Yeah.
And I have so many people in recovery that I know that have gone and done it.
Mm-hmm.
And it's always in like Peru or like somewhere in South America, and they come back with these like huge emotional experiences and this emotional purging and insights. They're usually done around ceremonies,
Yeah, definitely a
and yeah,
ceremonial, ritualistic.
growing in popularity amongst like trauma survivors and people that are undergoing trauma and they want to like heal their trauma. Um, but there's also been like deaths reported,
Mm-hmm.
right? From unregulated settings or like someone having too much of it or something happening at these remote retreats. I don't know how often it's happening. I don't know the data around that,
Yeah.
but like I have heard incidental things.
Yeah, it's very very unregulated thing, first of all,
Right.
but it's also like a very uncomfortable thing. It there's a lot of puking going on.
Oh yeah, I've heard about the buckets.
Yeah.
Yeah, they like
And
that's
so
the purging that happens at the beginning of it,
yeah,
right? They just have these huge buckets of people vomiting.
yeah. And the health risk around this specifically is the dehydration,
Right.
because then you can't eat, and this isn't a short-term thing. This is these days.
Okay.
And so there's the onset, and then the half-life of DMT typically is super short, but the inhibitor in the plant allows it to be digested and then distributed orally, where typically it's done different,
Mm-hmm.
a different way, right? But the inhibitor allows you to then ingest it, and it's bioavailable through your ingestive tract, and it just elongates the process, but it makes you super sick up front. And
Interesting.
and so what I've heard is that you're literally on an IV drip,
Oh, to
um,
keep you hydrated.
to keep you hydrated. But if that's not happening, because it's unregulated,
Right.
and if it is supposed to be ceremonial in nature and all this
How are you
stuff,
getting these drips in there?
right,
Right.
right, because
Yeah,
people
like
are
a
literally,
D5 normal saline, like
you
yeah,
hear about these stories where it's like people are out in the jungle with a witch doctor
yeah,
doing this stuff, and
yep.
it's like, and then you hear about the other one where it's like this guy's like literally in like a luxury bed doing this stuff, and that guy has the drip, but
Uh huh.
then it takes away from the ceremonial aspect of it.
Yeah.
So it's, it's
It's
very, very
interesting.
unregulated.
Yeah. So I mean, like the side where they're going and doing it right in terms of like addiction risk, it's like there's a low physical dependency to it.
You're talking about addiction risk to plant medicine.
Yeah, or especially ayahuasca, right?
Mm-hmm.
But there's a huge pull to it,
Mm-hmm.
right, psychologically, and there's a lot of identification, right, around the identity of addiction and the emerging concerns around ayahuasca for like repeated spiritual highs
Mm-hmm.
and spiritual uses. Um, so I don't. It's just it's. I have enough friends that have gone through it, and I don't want to judge them because like I respect their recovery,
Mm-hmm.
and it's a personal choice that everyone needs to make, right, as to like how they want to go about it and what they want to do.
Yeah. So MAPS actually, because DMT is ultimately the chemical that they're accessing in
Mm-hmm.
ayahuasca. MAPS did a drip, an IV drip of DMT. DMT is typically,
I've heard about it, right? I mean, I I had a sponsee who was like, "All right, look, man, I really want to be sober, right? But if someone brings along DMT, like, I'm definitely gonna do it." And I was like, "What? Why? Why that one?" And he's like, "Absurd stories."
yeah. Let's see what this guy say. So Nate again, he's tried the whole alphabet of psychedelics in pursuit of self-exploration.
Yeah. Is Nate in recovery?
Nate, are you in recovery? Oh yeah, it says that he's clean now.
Okay.
Um, this year, he reached the same ego death in meditation
Yep.
that he experienced with LSD. That's
And that
awesome.
and this goes back to like spiritual shortcuts, right? Of
Mm-hmm.
like, I mean, one of my favorite books is "Be Here Now" by Ram Dass.
Yeah.
And it talks about how when he was the professor over at Harvard, he did so much LSD that he was like trying to find this state and stay in it. And he couldn't stay in it because every time he would go up, he would have to come back down. No
Mm-hmm.
matter how much he took, he always came back down. And that the only way that he found to be in that state perpetually was like through prayer and meditation.
Yeah. So that's what he said. That it changed everything for him. That there was no substance needed to
Yeah.
get the same
To get
effect.
and to stay in it, right?
Mm-hmm.
Because you've done the work of letting go of all the stuff that you're holding on to.
Yeah.
Yeah. That's awesome.
Yeah. Okay. So what happens neurobiologically during psychedelic use?
Okay, so this goes back to what we've been talking about, right? In the quieting of the amygdala and the fear circuits, and basically getting reset. And what we're trying to do is like build prefrontal pathways around that time. So like that's why it's hard for me to say not to go do it,
Mm-hmm.
because it fits into the model that we're proposing, right? In like we've got a hyperactive amygdala, and you are trying to do whatever you can to build new prefrontal pathways to quiet down that hyperactive amygdala, but it's done in a hyper drive way,
Mm-hmm.
like super quick, super like fast, when you could accomplish the same thing, but it would take, months of recovery, months of therapy.
Mm-hmm.
And so you're doing it in a very, very in a quick way.
So what you're talking about is the quality of it. Like, what is the actual quality of the effect?
And I don't know, right? Like it's if you built the pathway and you're getting the BDNP to reinforce it and to permanentize it, right? Then is it the same thing? Like did you just do a shortcut? And it's like a shortcut to like getting 5 years of recovery in the first year? I don't know. I
Yeah.
mean, I just it I my fear is that there's such a high potential for abuse that if you didn't need to do it and you were doing okay, then why go down that route?
So what I have heard is like it's the enhancement, right? Because I've heard of people who had substantial amounts of recovery that were
Uh
going
huh.
down and doing these things,
Yep.
and it's just like working out. Like a lot of people will work out and they plateau and they use enhancements or enhancing drugs to get even better, right? I don't know if this does that as a one for one around
Mm-hmm.
like working out, but in theory, it definitely sounds like logically sound. I just don't know if up front the first thing that you want to do, like a week into your
Yeah.
recovery, is
No.
go.
Yeah. Like,
Yeah.
but then this goes back to like build your community
Mm-hmm.
and then figure out the right path for you. And
Yeah.
so it all comes back to building community. And then this goes into like the spirituality of it,
Uh
right?
huh.
And so it's prayer and prayer and meditation, right, activates the.
So wait, how does spirituality specifically influence neurobiology?
So it's the release of the oxytocin, right? And the meditation mirrors the psilocybin brain patterns that occur. And then when you're getting into those particular state, gratitude enhances serotonin release. Uh,
Really?
yeah, and then surrender lowers cortisol, right? So you're doing spiritual practice to change your neurobiology. You
Okay.
can do that through a spiritual practice as well, right? You don't have to have the drugs for it.
So you know what? I have somebody that wants to talk to you specifically about this, around what do you think the benefits like neurologically are of having like a deep spiritual connection through a religion?
I think it's awesome.
Yeah.
I think it's great.
He wants to get in like the granular of it with you though. He wants to like really talk about like, do you think
So
that I am because what he's really talking about, I think, at least what we briefly talked about is it's Ian,
okay,
is the forgiveness aspect
yeah,
of his religion.
yeah, no, and that's amazing, right? Like radical forgiveness. I think that it lets go of all of the pain and all of the harm that's there, right? So whatever you can do to get yourself out of a state of fight or flight, I'm all for it.
Yeah.
100% for it. Like you'll never see me be like, oh, don't go do that, right? My dad had this philosophy on religion, right? Because when I was younger, like you struggled with, what's my faith? Like, should I go down this route? Should I go down this? And my dad was like, I don't care what you do, right? He's like, I don't care what religion you are, right? No religion's gonna tell you to go kill anybody,
Mm-hmm.
right? And it's gonna be like, be a good person. So be a good person, you'll be fine.
Yeah.
And I was like, okay, thanks, Dad. So basically, was like he absolved me of like he's like I don't care if you're Hindu or not. I don't go do whatever you want to go do, right?
That's so I think that that's probably like a really healthy way to address children in their spirituality is
Right,
just go just go explore it. Don't
right. I don't need you to be what I was.
yeah.
I mean, he sat me down when we were little and we watched like Mahabharat together, which like these like videos, and he like loved watching it. So like those are like my best memories of my dad bonding together because he would be like, look at this and like look at this, like watch this, and so those were great memories. But he never forced it onto me.
Yeah.
Very different story with my mom though, right? My mom was like, you have to go do this. Like this is a requirement. This is a must.
Do you know who Richard Dawkins is?
Mm-mm.
I think I've asked you this before. Anyway, one of his books, the book is called The God Delusion.
Okay.
He said, and it rang so true for me, but he said, "There's no such thing as a Christian child. There's only children of Christians." And ultimately, what it said to me was like that children inherit their parents' beliefs
Yeah.
unless you allow them to develop their own.
Right. Or they rebel against their parents' beliefs until
Oh yeah, that's what I
yeah.
did. So, Mr. Buttermaker, I don't know if anyone has seen the 2017 documentary called Trip of Compassion that follows patients receiving MDMA-assisted psychotherapy for PTSD. It's a good watch, he says.
Okay. What's it called again?
It's called Trip of Compassion.
Trip of compassion.
Yeah, definitely gonna have
We'll
to.
we'll make that text that to me too.
Yeah.
We'll make that a watch for everyone on staff,
Okay.
right?
Uh,
When we have our movie nights.
yeah.
Okay. Um.
This next part really is gonna apply to Nate. So why is the integration essential post-treatment?
Right, and it's just it converts those epiphanies that you have during these high states of neuroplasticity into practical everyday behavior. And so when we talk about neuroplasticity, it's not just forming the new thread, it's reinforcing it
Mm-hmm.
over and over and over again, right? If you don't use it, you lose it. So
Okay.
like I mean neuroplasticity, right? The saying is neurons that fire together wire together. And repeated firing over and over and over again strengthens those particular connections. And so you have to have the repetition of reinforcement, right? But that also prevents relapses into escapism, right? So you're not using the drug to just escape that reality. You're actually living that particular life.
Okay. So what are the major what are the
Sorry,
major no, you're good. What are the major psychological pitfalls around these drugs?
it's the dependency that forms, right? It's the bypass of using this particular drug to solve and resolve unresolved trauma. right? And then the idea like, oh, I had this spiritual experience, but it was drug induced, right? Especially with lack of supervision and the breakthroughs that might occur in isolation or like by yourself that you're not really integrating over and over and over again.
It's funny that you say this because I remember specifically having experiences when I would do mushrooms.
Mm-hmm.
And the first, like, probably couple dozen times that I did it, I would have these amazing moments and just completely forget it. And so after that, we started doing like trip journals where we would write the stuff down,
Okay.
and half of it was
Could
incoherent.
you even see it?
Oh yeah,
Okay.
yeah. Half of it was incoherent, but there would be
Just wait.
things.
The more you describe what you were able to do on mushrooms, I'm pretty sure I took acid.
Oh yeah, no, acid is not. It, if you do enough of it, it is seriously disassociative. There,
Okay.
you're not in the same planet.
Okay. Yeah, I think that's what I did. I
Yeah,
think I did. I think I did mushrooms laced with acid.
mushrooms aren't like you will get light visuals, but a lot of it is like manipulation of patterns, like in things. So you'll see trees move that aren't moving.
Oh wait, then maybe I did. I don't know.
LSD does the same thing,
Okay.
but that
How
is
long
like
does it
the
usually last?
LSD.
No, mushrooms.
It can get so 4 to 6 hours.
Okay, I was gone for like 12 hours.
Oh yeah, no LSD.
Okay. All
Yeah,
right.
it takes like an hour to onset. It takes maybe an hour and a half to two
Yeah,
hours
this
to
was all
peak.
this was all day New Year's Eve,
Yeah,
right? This was New Year's Eve at like 8 o'clock until
8 in the morning.
noon the next day. And
Oh yeah,
I went to the Rose Bowl that day.
really?
Yeah, it was insane.
Just burnt out.
I was I went to the Rose Parade, and I didn't go to the Rose Parade. I went to like somebody's house, but that we thought was gonna be a house party, and there wasn't a house party. So it was me and my friend Greg that were just sitting outside of like this house, like, and I was tripping, and he was like, "I'm never doing that again," right? It was
Oh,
like a
the whole over and over and over.
not a good experience for me, right? And he's
Hmm.
like, "But I'll sit with you, right? But this is the worst New Year's ever," and I was like, "I'm so sorry," and I was like so fucked up, and like I think back to that time, and I was like, I remember seeing these people, and they're like, "Hey, man, let's go to the next level," and I was just like, "No, I think I'm good. I think I'm just gonna stay here for a while." Right? They're like, "Are you sure you don't want to come on to this like plane here?" And I was like, "No, I like it here on Earth. I'm gonna stay
Yeah,
here."
yeah, yeah. Those were not real.
Okay, no, I'm clearly not
Okay,
real,
all
right?
right.
Clearly, I knew enough about
All
that
right.
for that not to be real. But I was like, acid or mushrooms?
Definitely acid.
Damn.
Definitely acid.
See what I like? I'm getting all these reframes now, right? Because this entire time I thought I'd taken mushrooms.
No.
Okay.
So speaking of framework, what defines a balanced recovery framework?
I think for me, it's a lot of mind, body, and spiritual alignment, right? Through structure. And you're looking at like the ethical guidelines and making sure that you're consistent with your own spiritual world, right? Like, is this okay for you? Like, is this okay for you to do? And so for
I skipped
me,
some shit, huh?
it's all right. I
All
mean,
right.
you've been skipping some shit like the whole time.
All right.
So what that looks like for me, right, is having clear boundaries between what is the medicine side of it and what's my recovery side of it, right?
Yeah.
And not relying on both of them to be integrated together. Because I have to maintain my recovery and maintain my sense of self,
Yeah.
right? So for me, right, if I went and I did like ayahuasca without checking in with my sponsor, like I would have not been okay with that
Yeah.
because that would have left me disconnected from him,
Mm-hmm.
and not allowed for me to feel that sense of connection, right?
Dude, knowing you, it would ruin the whole thing.
Ruin what whole thing
The whole experience of going to do that ayahuasca trip.
without letting him know.
Yeah.
Yeah,
It
without
would
with
completely because that you
yeah,
would
because
focus
in the
on that.
back of my mind, the entire time, I'd be like, oh, I didn't check this in, right? Like I'm self will run riot. There he goes again, right? Doing whatever he wants to go do. And so, like, I think for me, having it be consistent with the way my spiritual world works is
Mm-hmm.
that I'm not doing things without checking in with people, right? Because I can't see my blind spots, right? Like you just like the stuff that you talk about, right? Like self critiquing self.
Yeah.
I have to check in with people to make sure that what it is that I'm doing is in alignment and I'm not kind of going in and doing like my own thing.
Yeah.
That's when I get into the most trouble And that's when I second guess myself the most,
Okay.
when I'm doing things on my own.
Okay, so what is the shadow side of this medication movement?
I mean, shadow side, right? I mean, it's is it over commercialized, right?
Oh yeah.
Where's the money, right?
Okay.
Follow the money,
Mm-hmm.
right? Follow the money, and we'll see, like, where is the real driver for all of this? And I think a lot of it's not the money, right, changes everything, right? And then it goes back to like, well, how much of this is profit or how much of this is like actual care, right? And then the boundary violations that we saw with MDMA
MDMA.
with the providers. Um, and then I think it's just a lot of the capitalism, right, that comes in with, are you profiting off of these religious rites that they had for like ritualistic things?
It's funny because your friend, that text message chain that you started to see last night,
Yeah.
those are ancient rituals. Talking about like we referenced one that taught it goes back like 3,000 years.
The reindeer one?
No, that one's more. But the Brian Moore Rescue and around like early studies, and so one specifically was the Oracle of Delphi,
Okay.
right?
Oh, that's what that was?
Mm-hmm.
Those were mushrooms?
Yeah. No, no, no. But they were using psychedelics.
Okay. Okay.
Yeah.
Back in Socrates' day.
Yeah.
Yeah, that's a while
So
ago.
actually, they think that all of those philosophers around that time, they were participating in psychedelic rituals.
No wonder they were so smart,
Mm-hmm.
right? I mean, the birth of modern medicine,
Actually,
right?
it was the birth of democracy as well.
Yeah,
The birth of a lot of things. They can kind of tie it back to these psychedelic rituals.
right.
And he has like books and books and books about this stuff where he's actually gone back and like tested vessels that they would use that
Oh, to see
contained
if
it.
there was like
Yeah, and there
any
was like
traces of it.
high doses of psychedelics.
Interesting.
Mm-hmm.
I mean, that reminds me of like 2001, right? Where like, consciousness jumps, right?
Mm-hmm.
When you're like, when certain things get introduced into the environment.
Mm-hmm.
Yeah, interesting.
Cynthia wants you to come on her podcast to do a sex addiction episode. She has
How's
her podcast is called Crazy Gutsy.
crazy gutsy?
Yeah.
Okay. Uh, Hey, tell Cynthia I'll give her a call on my way home.
Okay.
I've been meaning to like reconnect with her. I think I called her like 2 weeks ago or like last week.
Okay. So, how should clinicians like deal with and navigate spirituality?
I think that as a clinician, right, I have to respect where my patient is at.
Okay.
Right. So like me in my practice, right? I try to meet them where they're at and with what they want to do. Especially when it comes to like mystical frameworks. Like I've had patients ask me about ayahuasca.
Okay.
And sometimes they'll ask me in early sobriety, or sometimes they'll ask me like 5 years down the road, right? Because
Mm-hmm.
I still have patients that I still see that have got 5 years of sobriety, and I try to tell them like, hey, it's your journey, right? Who am I to say how this is all going to unfold for you, right? But all I want you to do, and I go back to the P11 pamphlet whenever I talk about that stuff, right?
Mm-hmm.
Is like, I just want you to practice the principles to the best of your abilities. So what that means for me is, before you go do it, thank you so much for checking in with your physician about it, right? And like being honest with me about it, so that I know what not to give you when if you're like, oh, I'm gonna go take some ecstasy. I'm gonna be like, oh, I should probably take you off of this antidepressant that you're on, right?
Yeah.
You shouldn't be mixing those two together. But at least you're being honest and talking about the things that you're going to be doing before you go do them.
Yeah.
And so it's being open to those particular things and not closing myself off to the idea that, hey, this might be something that works for you. Right. And I don't think I'm going to tell anyone to do anything that's like inherently harmful. It's just, what is that? What does your recovery look like? Where do you want to go with this?
Yeah.
And then trying to give them as much information as I can about, here's the biology of it. Here's what it looks like.
Okay. Ethics and program integration.
Okay.
What ethical standards should and need to define this field around
I
these?
mean, we've talked about that, right? In terms of like having informed consent, right? Like that's the biggest thing of like, what am I actually getting myself into? Right. And having patients know like, hey, this is ketamine. This is what ketamine does to you, right? And really giving them informed consent of like the different risks and the benefits that are coming from getting an IV infusion, right? Like that has its own inherent dangers as well, right? And especially to be trauma informed, um, and making sure that I'm not treating someone that's highly traumatized and going in there and opening something up that I'm not going to be able to close up in that one particular session, right? And then peer reviewed and just what does it look like to have a process, right, that's standardized and that isn't going to be dictated by the personal preferences of that particular provider, right? To be like, oh, like I know how this should work, right? As opposed to this is the standard of care, right? But I don't know what that looks like, especially when you have a therapeutic component to it, because everything is when you start getting into therapy, right? There is so much of it is dependent upon the provider itself
Oh yeah.
and how good that provider is or how much you connect with that provider. Because I've had some amazing therapists, right? I've also had some shitty therapists,
Yeah.
like back in the day, and like you know the difference,
Yeah.
right? Of like, oh, like this guy, they have this calming, grounding energy to them.
Yeah.
So it's tough to get that at scale when you're trying to recreate something that may be dependent upon the provider that you have.
Well, additionally, the individual experience is so subjective.
Yeah.
There is no like across the board experience in any way. There
Right.
might be similarities to the experience, but it's almost like almost 100% of the time different. And it's the exact same way without drugs.
Uh huh.
Without any kind of medication assisted therapy or treatment or recovery, it's all so different.
Right.
And they could be addressing it the same way. They could be going to the same meetings, they could be going to the same rooms, and still be dealing with their recovery so differently.
Yeah.
Okay, so how do addiction programs adapt these different modalities
I
safely?
mean, do you see us ever doing this?
So, from where we sit today, no.
No. Yeah. I mean, if there was more evidence and more efficacy, like maybe, but I don't think that that's where we want to focus our stuff on, right?
Yeah,
Like
no.
that's not where that's not our that's not our thing. That's not our like what's where to put it? It's not what distinguishes us from everyone else.
Right.
But there may be treatment facilities out there that are like, hey, come get sober with us. We offer this,
I mean, there are.
right? But in Mexico.
Well, no, there's so when you're talking about like ketamine, there are treatment centers that offer it in
Oh,
conjunction.
really? Like while you're in inpatient?
Yeah, outpatient,
Interesting. Okay.
in conjunction with TMS, actually.
Okay.
Um,
And this is like for alcohol and drug recovery.
mhm.
Okay.
I know of one,
Okay.
um, and it can't be the only one. There
Right. I mean,
probably more.
yes. Yes.
I mean, I've actually been to it,
Oh yeah.
not as a client, but just to
Okay.
go see it. It was in Washington State,
Okay.
but Mr. Buttermaker says the therapist's theoretical orientation might be one important factor to consider around this stuff, which is yeah what we.
Yeah, and how they see the world, right? Or
Mm-hmm.
how they approach the patient and they care for the patient.
Mm-hmm.
I hope that everything stays evidence based and they collaborate and they stay in line, at least for me, with the modalities around the 12-step world, right? And like kind of follow those principles and like keep people in community, and maintain an absence focused model post treatment as well. Not to be like, oh, after you do this work, you can go back to drinking
Yeah,
like a gentleman, right? It should be fine.
yeah, it is the foundational principles that you're talking about, right?
Yeah.
And it's funny because when I hear you say things like when you talk about the 12-step framework, I know what you're expecting around that as far as outcomes, right? But not everybody that's listening to this is familiar with like what we're actually telling clients around that.
Yeah.
And
It's
so
for me. What do you think? What do you think it means when I say that?
I mean specifically for what I assume you mean is around the model,
Yeah.
and ultimately what we're saying is if you need to quiet the amygdala, then you have to do these specific things.
Yeah.
And so really we're telling you to do the same thing but for a different reason. Which, like I told you, that would have sold me on it up front. Like instead of should telling me why,
Yeah.
you can sell me on that all day.
Yeah. The why.
On the why,
Yep.
yeah.
That's the plan.
So, what is the next psychedelic innovation, do you think?
I I don't. So I tried to find out if there's any like new analogs coming along, and I
Mm-hmm.
couldn't find anything. I think there's like AI assisted integration. Like you can get an AI
Oh, wow.
to like do the ketamine and then talk to this AI, right? But like that's scary for me too,
Mm-hmm.
because I mean, like I don't know what's gonna happen with that. But they're doing more and more of that in treatment.
You know what's funny? Like when you think about like an AI doing this kind of therapy with ChatGPT, like my ChatGPT app knows me. So like I'll ask it stuff now and it'll be like, "Well,
Yeah,
since you referenced this before, do you want me to talk about it in this way or are
yeah,
you
yeah,
asking like
yeah.
arbitrarily?"
They'll be like, this is a great question for your book.
Yeah.
Do you want me to put this in as like do you want
Crazy.
me to integrate this into that? And I was like, oh, it knows me too well. But
Yeah.
at some point, they're gonna sell all that data to somebody,
Oh yeah.
right? Of like,
And so imagine like doing therapy with somebody like this. And
right,
eventually, I think that there will come a day where all of these systems are integrated,
yeah,
at least in a back channel way, if not up front.
yeah,
And it will be able to communicate like, oh, this guy's fucking psycho.
yeah.
Like,
Or I hope that's not the. I hope that's not
well, I mean, what
the
HIPAA?
pathway that we start to go down, right? But what I think, because this isn't HIPAA regulated, right?
At
ChatGPT is
all.
not HIPAA, like you're dumping all of your personal information into a system, right? That eventually is going to sell your data to somebody to sell you something better,
Mm-hmm.
and that's going to be the model. That's going
Mm-hmm.
to be the model of because we're in like a capitalist driven society, right? The more information I have about you, the better I am going to be able to sell to you.
So Nate says, what always struck me about recovery is the ready rescue of the addict with structure in the beginning that can open up to a complete overhaul of the mind, body, and spirit. Um, doesn't spirit come from us coming together? Isn't it where it comes from? Yeah,
Yeah, and
that's
until you, so for me, it's always I'm getting my oxytocin from the people around me,
right.
and so if I'm not in conscious contact with my higher power, at least someone else is in conscious contact,
Mm.
and so I can get contact with the source through that person when I'm not available to the source itself.
So the chemical reality of what we're talking about here. When you said this to me the first time, I was like, God damn. But you said that oxytocin is we and dopamine is me,
Yep.
and I was like, yeah, for sure.
Yeah, I keep forgetting to put that into the book, right? So there's an entire chapter on the difference between dopamine and
You
oxytocin.
definitely need to put that in there.
Yeah, okay. I will I'll make a note. I mean, I'm sure it'll eventually get there in the
Yeah.
second or third draft of it, but like right now it's not integrated very well into it. But I talk about half life, but you're 100% right. Like dopamine is responsible for my survival,
Mm-hmm.
right? Oxytocin is responsible for our survival and the things that you do that allow for us to get better, right? As a species.
Okay, so how should clinicians prepare for the future?
If they are so inclined, there should be certifications coming along with psychedelic assisted treatment,
Oh yeah.
and then learning about the ethical standards, right, around all of those things, and to make sure that it's a multidisciplinary approach. I mean, I think like what we're doing with like the true mat therapy is making sure that there is some component of therapy involved with the medication itself, and so it's not just one or the other.
Yeah, I think that that is a big problem around using medications specifically.
Mm-hmm.
Is uh, first of all, I think it also has to do with who's prescribing, but the problem is the prescriber is never the therapist.
Yeah, they can't be right. I mean,
I know they
there are
can't be, but that is a
right.
problem
The
where,
prescriber is not the therapist.
right.
Yes, because it doesn't. This goes back to economics of it all,
Mm-hmm.
right? Like it doesn't make economic sense for me to do the therapy,
Correct.
right? Because I mean, if I was going to charge you for that, right, it would be it would be through the roof, right? For like for an hour of like sitting down and like talking to me, which is not that's not feasible.
I mean, yeah. Um,
and I wouldn't be very good at it either, right? Because that's
well,
not what I was trained in.
for sure. Well, okay. So additionally to that whole problem is, so you're not trained in it, but also like, would that in some way hinder your ability to do your job correctly if you also had to provide that level of clinical oversight?
I think it would deeply hamper the amount of people that I could be effective with.
Yeah.
So it I, it doesn't make sense.
Okay, this is what Nate said. He said he loves that we can bridge that connection to the source for each other.
Yep.
Yeah.
Yeah. And so, but then that's why I go into communities. That's why I go into
Hmm.
groups like that, so that I'm fostering that sense of connectedness.
Okay, so what do you think the biggest risk to credibility is?
I think it's the over promising of this little pill right here is going to fix all of your problems.
Okay,
Right.
but I think this happens already anyway. I think it systemically
Uh-huh.
as treatment providers specifically. Maybe not on your side of it, but
Yeah.
my side of it is that we way overpromise and underdeliver.
I love the idea of when someone comes into my clinic and is like, Dr. Shah, you're going to help me cure my addiction, right? And I'm like, you are fucked if you think that that's the case, right? You think I'm going to do that? Like, oh, you're already in big trouble. Like,
Yeah.
they're just that's not what we're doing here, right? I'm going to point you in a direction, and it's going to be your job to go.
Yeah.
And if you decide not to, that's cool too, right? But I can't do that work for you,
Yeah.
right? And that work is of connecting, of like going and getting your oxytocin, going and finding safe spaces and doing all of that stuff. I think the problem with ketamine is that because it has such a dramatic effect after that very first time that you use
Mm-hmm.
it, that it's like, oh my God, like this is it, right?
Yeah.
This solves everything. But then you don't do the integrative work that's required of it later on.
Yeah. So it's funny that so your framework literally is with the addict and alcoholic. So my brother, the one that you know,
Okay.
he does ketamine therapy,
Okay.
and he said the very first time it was like massively effective. But this is the same guy that'll take 2 sips of a drink and leave it,
Yeah.
and so there is no like afterthought of him like being like, fuck, I wish I could do that like right now or whatever. It's like
Right. Right. Right.
he really like used it therapeutically. It had its effect, and now he's continuing on with the therapy part of it, and they
Right.
do it
Right. Right.
periodically.
I think it gets you out of that state, right? I mean, the more we've been discussing this, and the more that I think about it, it's stopping the hyperactivity that's
Yeah.
going on, and it allows for you, because we talked about it. The best way for you to build new neuroplastic threads is to be in a safe space.
Mm-hmm.
So if that drug
Naturally.
fosters that, yeah, naturally.
Yeah.
But if that drug fosters that for a day or two, then of course you're building new neuroplastic, the new prefrontal pathways in
Mm-hmm.
that point, right? Because you've quieted down the amygdala to the point where you're not in fight or flight.
Yeah. I mean, there's definitely benefits
Yeah.
to it. I'm just really hard pressed to say that it's a smart thing it's a smart thing in early recovery.
I'm never gonna say that,
Yeah.
right? I'm always gonna say my stance on all that. It's gonna be like, hey, why don't you do the 12 steps, and then we'll come back and we'll talk about it,
Yeah.
right? Like,
Foundation. Lay the
yeah.
foundation.
And so if you can accomplish that first, then by all means, right? Like, we'll discuss that afterwards. And usually what happens with people is that they'll go through that and they'll be like, oh,
Nah, I'm good.
I'm good.
Yeah.
Yeah, like, you're right, that shy. I really didn't need that. And I'll be like, okay. And so it's always like, why don't we do this first
Yeah.
and then see where you're at,
So
right?
what do you think successful integration looks like?
I think for me, it is someone who has gained enough insight into like their trauma and into the things that they needed the psychedelic to open up, that allows for them to maintain sustained sobriety, right? And it allows for them to have renewed emotional regulation, new awareness, strengthen their relationship with their community, and that sense of belonging. That's why for me, it was like I've had people that have done ayahuasca that have told me that they did ayahuasca, but they're like, I don't want to tell anyone else.
Yeah.
Right. And I was like, so you want to keep secrets from the people that you're around and that you're close to, right? Like that for me is like the quickest way to like not get my oxytocin.
Yeah.
And it's like I'm going into my safe space, right? And if someone like mentions something about, oh yeah, that guy did, ketamine, right? Like, can't believe that shit. And then all of a sudden, like, I'm like, oh, then my sense of fight or flight goes up,
Mm-hmm.
and I got triggered by it,
Yeah.
right? I would much rather go into a space where I'm not being triggered by stuff
Yeah. And so it's almost like, yeah, you may have benefited up front, but ultimately there was more damage on the back end.
because you lost your safe space, right?
Mm-hmm.
Especially if you can't talk about it,
Yeah.
right? If you're in fear of judgment or shame. But like that's the same thing that happened with you and the Suboxone,
Mm-hmm.
right? Like you went into a space that you thought was safe, and then you started talking about Suboxone, and they're like, ah, we don't talk about that over here, right?
Yeah. Yeah.
Like,
Yeah.
get out of here, you drug addict.
Yeah.
And so, like, how is that safe for you, right? So
Yeah.
then that's no longer your safe space. That's not a place that you can go to and down regulate out of fight or flight.
Yeah. To be fair, though, I never made it a safe place to begin with.
You never made it a safe place.
It wasn't, I didn't, I wasn't there for long enough for it to be like a
Yeah,
safe
you have to
place.
you have to bond with the group
Yeah.
before it becomes a safe space.
So it wasn't like a destructive path where it was like I built this safe
Yeah, yeah,
place and
yeah,
then
yeah.
no, it wasn't that. It was
It was never going to be that space for you,
right.
and that's fine. Like it's not for everybody,
Right.
right? But I mean, I'm sure there could have been some meeting in town somewhere where you would have mentioned Suboxone and they would have been like, dude, totally cool, right?
Yeah.
No big deal, or they wouldn't even have blinked.
Well, also, if the framework had been different, like if the lens was different and you said don't go there for what you think you're going there for, go there because you need to build these relationships.
Yeah,
I'd have been like, okay, like who gives a fuck if they don't accept me for that? Like
yeah,
they all
or
know it or whatever and they don't want me to talk about it, I just won't.
yeah, as long as you're not feeling judged and you still feel part of.
Yeah, but I have that benefit of being like antisocial, so they can judge me anyway.
I think you would have done fine at Lambda.
Probably.
They would have like not been. They wouldn't have even batted an eye. They would have been like, all right, whatever, dude.
Lambda is a funny demographic of people.
Yeah.
Because they're judged
What? Who's
by a
judged?
lot of the people that go to Lambda.
Yeah.
They're
That's I
like,
love Lambda.
yeah,
Like that's my spot,
mm-hmm,
right? Like it's super accepting, super like non-judgmental,
mm-hmm.
and definitely fit in there. Yeah.
Okay, so how do you think law and policy are going to evolve?
I mean, we talked about Oregon and Colorado, right?
Mm-hmm.
In terms of like what's legal and what's not legal now. I think the DEA scheduling is going to change in the
I do
next like
too.
couple of years. They're going to like start being like, okay, like this is not a controlled substance, right? Or like this has some therapeutic value to it.
Yeah,
It'll still be controlled, but it won't be a Schedule 4. I think Schedule 4 is like where it's like you can't use it for anything else
I
but
thought it
that.
was the opposite way.
Schedule 1.
Schedule 1, it
Okay.
has the highest affinity for
I
abuse.
always mix it up.
Yeah,
Yeah.
so yeah, the scheduling criteria around drugs has
Uh
always
huh.
blown my mind anyway because marijuana was a Schedule 1
Yeah.
and cocaine was a Schedule 2.
Well, there's medical
I know.
reasons to use cocaine, right?
Yeah.
There was you I remember in med school they were like, yeah, you can order cocaine, right? And there was like the surgeon that ordered this
Pounds of
much
cocaine.
cocaine for this purpose. It was like something about like local anesthesia that you
Mm-hmm.
could use it for. And so he's like, yeah, like we ordered some cocaine. We're like cocaine stat, and I was like, what? They're like, yeah, it was a thing. You could order alcohol too. They used to order beer.
Yeah.
You could order a beer
Well,
for a patient.
yeah, during prohibition, there was only the only legal alcohol was prescribed alcohol.
Right, for when someone was withdrawing from it, right?
Mm-hmm. Well,
Yeah.
not just for that. I think there was other uses for it too.
Okay.
But yeah.
Yeah.
Okay. So, what can addiction medicine uniquely contribute?
To this particular space.
Yeah.
Yeah. So it's just oversight, right? To being like, hey, like let's watch out for the abuse potential.
Mm-hmm.
Let's not just go into it and be like, all right, everyone get some ketamine, you get some ketamine, you get some ketamine.
Yeah.
Like let's sit down and think about where it is that there is potential for abuse and then just be mindful of it.
So again, more awareness.
More awareness around that, yeah, and understanding the risks of relapse, right? What happens when somebody is abusing it? What are the signs that somebody's abusing it?
I'm gonna be interested. Like, I'm. I wonder how SAMHSA is what their hand in this is gonna end up being.
Uh huh.
Um, because that's the government arm that
Right.
oversees all of the addiction medicine space.
Mm-hmm.
So I'm sure they're gonna have to weigh in on this because there are representatives from SAMHSA that actually go and like talk to the White House
Yeah.
about this
Yep.
stuff.
Yep. about like what is our policy on this.
Yeah. Do you ever get on their website?
No, I have. I have back in like when I first started. But there's just so much information there, right?
There
Like
is
there's just
a
like I
shitload of
can't.
it. I
You
mean,
have
yeah,
to find your niche and like be really, really good at that one particular thing, right?
yeah.
I can't know everything.
You
Yeah.
can't?
There's just no way. No way.
Okay. So I think
Okay,
that's it.
that's it. Yeah. All right, good. We did solid on this one.
Yeah.
Yeah. Okay.
We didn't make that 3 hours.
That's the goal.
Yeah.
That's the plan, right? To be very targeted and very focused.
Yeah.
Okay.
Okay, everybody that's still here, thank you. We appreciate it. If so next week, do you want to do next week or you don't
No, I
you
thought
want
your
to go
baby
to
was coming next week.
Wait, the baby comes next week.
Yeah.
Wait, no, the baby comes next Thursday though.
It's Thanksgiving.
Next Thursday.
Wait, your baby's being born on Thanksgiving?
No, Wednesday, sorry. Comes Wednesday.
Okay. What? Go spend some time at home.
All right.
The day before. Yeah, that would be great.
Okay, guys, we will see
Who's
you.
the workaholic now?
Okay, we will see you guys in 2 weeks.
Okay.
Thank you all very much. Thank you. Thank you, Nate.
All right. Bye.
All right, bye guys.